Okay, moving on to our second work session. We'll have a discussion presentation on local board of health and supporting governance structures from Wasalfo. So, is it Jamie?
Yes, can you hear me, Counselor?
Yes, we can. Welcome. Thank you for being here
Well, thank
virtually.
you. Appreciate the invite, and hopefully it won't be redundant information, and hopefully it'll be helpful to, I know, some conversations that you are having as the council, as well as your advisory committee as well. So go ahead and move to the next slide, please. So public health, you're probably aware of this. We use a lot of acronyms. I will do my best to try to not use acronyms, but here are some common ones that I might occasionally slip into just because they roll off the tongue quite easily. But if there is something where I say an acronym and you're not quite sure what that means, please stop me and ask, and I will clarify. Next slide. So I just want to start and say thank you. Thank you for your service. Thank you for your leadership. I come from a place of public health, and that means different things to each one of us. So we have, different motivations and bring different perspectives to serving on local boards of health or local government. And public health is at a really critical point in time. So I appreciate the chance to have dialogues and discussions like this because it's very, very important right now in kind of our lives. And the local board of health is really important to public health outcomes, and having a strong local board of health contributes to strong local public health agencies. So again, just want to say thank you. Next slide. So I know many of you in various spaces, but again, just want to say my name is Jamie. I'm our managing director for the State Association of Local Public Health Officials, or WASALFO for short. I've been in this role since 2017 and have had the privilege to get to work with the 35 local health jurisdictions in our state on a wide range of public health issues. Next slide. So really briefly, our mission as WASALFO is to advance the interests of local public health, improve the quality, capacity, and leadership of our local health jurisdictions and agencies, to build an effective and efficient public health system in Washington state. We are a critical component. Our local health is a critical component and sector for governmental public health in Washington. And I get to help make local health as strong and capable as possible. We do that through a variety of things. We contribute to policy. We advise and collaborate with our state partners like the Department of Health. We educate, inform policymakers on a wide range of public health issues. And we also participate in a lot of discussion and networking within our own local health system as well. Next slide. So really briefly, a quick introduction to local health to just kind of level set what that looks like across the state. Next slide. So Washington's governmental public health system is home rule. So that means it's a decentralized public health system where local health jurisdictions are governed by a local board of health. That means that the state health department does not have governance or oversight over local health agencies. That is governed locally. So you'll hear home rule or local control in terms of local government. That also applies to local health jurisdictions. Now, there's a couple of different ways local health is organized. It could be through county departments, like Clark County Public Health. It could be through health districts, which are kind of like special purpose districts, and those could be single county. A good example of that is Kitsap County Public Health District, or multi-county, so the Benton Franklin Health District. They're special purpose districts in that they are adjacent and connected to county governance, but they are not under county governance structure like a health department might be. We also have other governmental public health partners at the state level. That's the State Board of Health. They really do a lot of the public health rulemaking, or those WACs that you talked about earlier, around various topics: notifiable conditions, food safety, on-site septics, vaccines, other things. They also do health impact reviews with the state legislature to provide information on the health and potential health impacts proposed legislation might have. We also have our State Department of Health that's led by the Secretary of Health, and they fund, administer, and direct a number of statewide public health programs and provide a lot of technical support and centralized functions for our state. So technical support around things like drinking water, centralized functions such as the State Public Health Lab or data systems. And then we also have tribal nations, health centers, and urban Indian health institutes. So those 4 entities really serve as our governmental public health system. Next slide. This is what local health jurisdictions look like across the state. So as you can see, we have a number of jurisdictions that are health and human services agencies under that county governance structure. That would be the dark gray. So Whatcom, Skagit, Cowlitz, Lewis County, Skamania in the southwest. Then we also have a number in the light gray that are county health departments. So they are just doing the public health functions and not necessarily the additional human services functions like housing, veterans, disability, that kind of thing. So Clark County would be one of those. We have some single health districts: Yakima, Grant, Okanagan in that kind of darker pink, and lighter pink, those multi-county health districts that I mentioned earlier. And then we have 2 kind of gems that are city-county health departments. And that structure, there's a statute that's specific for city populations that are over a certain size. They can be actually a city-county. So Tacoma, Pierce, and Seattle King are city-county health districts as well. Next slide. So public health authority lies in a couple of different ways. There is some components in the state constitution, and then the State Code of Washington, or the RCW. There are a lot of statutes around public health authority, as well as state administrative codes, or those WACs. So the big one that's highlighted is Title 70. That is a very important RCW for local health. That is where local Board of Health authority lies. It's where your health officer authority lies. It's where other statutory duties for local health jurisdictions lie. So that Title 70, really, really critical. There's also components for public health authority in Title 43. That's really state government executive. Title 43 is explicit to Department of Health. And then Title 36 is around counties. And there's some county responsibilities around public health as well, particularly around funding. And then your state administrative codes, I've just given you a couple here. Title 246 is the Department of Health, as well as that State Board of Health. That's where a lot of rulemaking around notifiable conditions and other things lie. But then there's also Title 173, Department of Ecology. We might dip our toe into some of those WACs, particularly around water quality and kind of that environmental health connection to a lot of that work. Next slide. So drivers of local health jurisdiction work, again, laws and rules are a big one and an important one. Those are passed by the Washington State Legislature as RCWs, and then state agencies pass those rules. They are often authorized to do rulemaking through the state legislature. But then there's also things like block grants and state grants that are categorical and specific. So a couple examples of those at the federal level is the Maternal Child Health Block Grant, where you could guess it, you are doing maternal and child health work under that grant. Public health preparedness, you are doing public health preparedness work under that grant. So it's very categorical and specific. It's driving the work that you're doing. But then there's also things like your chief health strategists and the Public Health 3.0 framework. And that is a framework that public health uses to center local health as that strategist, convener, bringing people together. So the resolution that the local Board of Health passed this morning around help, kind of having the public health department as that third party entity on that prenatal discussion, that is a very chief health strategist role and function of the health department. You're bringing people together to have a discussion, to develop recommendations and strategies to solve a very complex issue. And then you also have local needs and priorities that are reflected through the Community Health Assessment and the Community Health Improvement Plan, CHA-CHIP, respectively. Next slide. So expanding local boards of health. Next slide. Recently, there have been a lot of statutory changes, so through RCW, around local boards of health. Before 2021, the county legislative authority served as the default local board of health and could pass an ordinance to expand the membership if they wanted to. So as charter and non-charter counties, you could say, okay, we want our local board of health to serve our legislative authority. So in the case of Clark County, the council, in case of other counties, the Board of County Commissioners to serve as the local board of health. Or they could, or you could have said, hey, we want to have membership that includes city, or we want membership that includes healthcare. And you could pass an ordinance to do that. And then in 2021, there was a House bill that passed, and it required local boards of health to expand their local board of health membership unless specific criteria were met. So that option of expansion was now a requirement. And then those additional categories of membership included having public health and medical expertise, a community member or partner, membership with someone who had lived experience or received public health services one way or another. And then for those counties that had tribal reservation trust or UNA land, usual and a custom area, tribal government as well. And then most recently, this past session, another House bill passed that clarified changes made to the tribal appointment process and tribal organizational membership. It was ambiguous when it passed in 2021, and clarity was sought this past session to help reinforce the importance of tribal membership, but also clarified processes that were a little bit ambiguous. Next slide. So in implementing 1152, again, 2021, we already had 11 local boards of health that met the criteria or were explicitly exempted from that required expansion. So one of those, and that could be that they had an existing public health advisory board, public health advisory committee, community health advisory board, community health advisory committee, all kind of different titles for the same entity of there's a community led body that provides advice and recommendations to the local board of health. So of those 11 LHJs, one elected to move forward with expansion, and that was Public Health Seattle King County. And then we had one that was required to expand after they moved. They were a health district, and then they moved to be under county governance structure. That change in kind of their organizational structure obligated them to to expand, and that was Snohomish County. And so that left 24 local boards of health that were required to expand by 2022. 14 of those 24 already had some sort of expanded local board of health beyond that county legislative authority. 10 had community members. 10 had other local elected officials only, such as city elected officials. So we already kind of were on a path of expansion. And so 1152, depending on what local health jurisdiction you're at, you either had to continue to expand or go through the full expansion process. Or if you were exempted, you could stay exempted. So as of this year, all local boards of health are compliant. And I say compliant as in there is no entity that kind of checks off the list that says you are compliant. It is self-compliant. But as of this year, all local boards of health have done what they needed to do to meet the criteria outlined in 1152. 6 local boards of health have maintained the county legislative authority only, Clark County being one, with the council serving that dual role as the legislative authority as well as the local board of health. Next slide. So some examples of what this looks like: Spokane is the biggest county to the east. They are a health district. They did not have a community health advisory board that existed in 2021, so they were required to expand their local boards of health. Whatcom County, like Clark, they are a charter county. They are a health and human services agency, so they have that expanded role as beyond public health. They also had a community health advisory board in place in 2021, so they have maintained the county council as the local board of health, similar to Clark County. Cowlitz County, just to the north of you, they are also a county health and human services agency. They did not have a CHAB in place, and so the expansion was required. And then I mentioned Public Health Seattle King County, also a charter county. They are a city county health department. They had expanded their local board of health pre-2021, and so they elected and city county health departments were exempted from the expansion under the original rule, but they decided to further expand what they had already expanded pre-2021 to fulfill the RCW requirements. So they were one that was already on the path of expansion and decided to let's expand so that we're compliant with the statute. Next slide. So pre-2021, I would say Washington State was probably one of the exceptions in terms of local board of health composition, and now we're probably more closer to the norm in terms of composition. So most local boards of health, and this is nationwide, this is not just Washington State, so this is nationwide. This includes decentralized states like Washington, centralized states, and kind of those states that are a mix of both. But most local boards of health have at least one member who is a healthcare professional, for example. So you could see in the slide, 88%. For Washington State, before 2021, again, before that expansion requirement, we only had 8 LHJs of our 35 that had a healthcare professional on the local board of health. Now, again, everyone is compliant with the expansion. Those 6 LHJs that have retained their council, they have that community health advisory board that is required to have healthcare professionals on that makeup. So everyone has healthcare professionals in some capacity touching the local health jurisdiction, providing recommendations, advice, advisory, serving in an advisory capacity or oversight governance capacity. Next slide. And again, additionally, I've just highlighted a couple of things. The bigger rectangle, and I apologize for the colorblind folks in the room. So the bigger rectangle that is over the first 2 things, that was really after 1152 passed. We now have those that are appointed specifically to serve on the local board of health. A local county council member, counselor, board, commissioner. In that role, you are automatically appointed to serve on the local board of health unless you have now a local ordinance that states otherwise. Pre-1152, that was the only thing that was designated to serve on the local board of health by statute. Now we also have other community members who are appointed specifically to serve on local boards of health. Again, that's those healthcare professionals, community members, those with lived experiences, tribal members as well. So now pre-1152, pre-2021, that red box, so that second point, that was solely the local board of health. Now we have expanded to include more. Next slide. So what does expanding a local board of health require? The county legislative authority is responsible for making any changes to the local board of health. That responsibility lies with, in Clark County's case, it would lie with the council. There has to be some sort of ensuring compliance with RCW for Clark County specifically, 70.05.035, which is home rule charter counties as a charter county. And there's the same requirements for charter counties, non-charter counties, health district counties as well. So it's different statutes, but essentially the same obligation. There's also a local board of health rule that was passed as part of that expansion statute. That is WAC 246-90. So any updates to local ordinances, resolution, or action that might be required to be made as local boards of health expand. Things to consider: membership categories, so calling those out and describing what those are, outlining a recruitment process. How do you recruit and then appoint people? How do you vet or interview or make recommendations for appointments? And then any governance roles, principles, processes that you might want to also include in those ordinances, whether it's an ordinance, resolution, action, having some sort of formal process in place. And again, there is no approval or confirmation process at the state level. All of this responsibility and all of this accountability exists at the county legislative authority level. Next slide. Some best practices I have observed in my role for local boards of health expansion, and this is, working across the state, working with various local health jurisdictions as they've navigated this. Having a county ordinance that outlines as much as possible is really helpful. The more you can formalize the process and the procedure, the more you can look at that as kind of your path and your directions. So the more that you can include things like in a recruitment process, an appointment process, roles, responsibilities, principles that you might use in terms of these are who we're looking for to sit on local boards of health, etc. Local Board of Health bylaws or other operating principles have been very helpful. We have a number of local boards of health who have an ordinance that kind of outlines the expansion, but then they have a bylaw that also goes into further detail of operating roles, responsibilities, other practices that they want to abide by. That's been really helpful too. So those formal documents can be really helpful. Some do local boards of health orientation for their new members. So if you're a community member, sitting on a governing board could be a new experience. There's new responsibilities you have around public meetings, record retention, those kinds of things. So having an orientation to kind of help get those new members aware of their new responsibilities can be really important. Having robust marketing and recruitment for positions so that people really know and understand what they are applying for or what they are being appointed to do, understanding their obligations, understanding their authorities, understanding their responsibilities. And then doing tribal outreach and engagement for those jurisdictions that have tribes within their jurisdiction to make sure that those relationships, if they don't exist, begin. If they do exist, are continue to be strong and respected with tribal sovereignty. Next slide. It's also really important to work with your local health jurisdiction leadership. So the role of local boards of health, providing that direction, recommendation, supervision of the LHJ. So you're passing local rules and regulations, you're setting fees, you're ensuring the agency operates and complies with state, local, federal mandates and laws and requirements. Your administration implementing your direction and vision, so that administrator director really serving as that arm for the local board of health to implement their vision and direction. So they're managing budgets, they're supervising and overseeing staff, they're responsible for the long-term program planning and operations of the jurisdiction. And then your local health officer overseeing enforcement actions and issuing orders around things like case investigations and control efforts. So that statutory authority belonging to the local health officer. They might be doing things like abatement or mitigation orders for environmental hazards. And then they might be helping navigate emergency declarations, health crises, things like that around outbreaks and other things. Next slide. So community health advisory boards, committee, panel, with home rule, everyone calls them a little bit differently. So I think Clark County is Community Health Advisory Committee, if I'm not mistaken. Some general roles and responsibilities. It's an opportunity to add community voice to public health policies and programs. It's a touch point to the community. It's a way to get the community involved and engaged. One, to hear questions that the community might be receiving on a number of different public health issues. Also a chance to provide education, messaging, communications back to the public. So that two-way kind of relationship being really important. CHACs can also provide additional connection and relationships to unique community sectors. You might have specific communities of focus within your jurisdiction that you want to prioritize. For example, if access to prenatal care is a big issue, ensuring that you have that perspective on a CHAC to help provide advice and recommendations to the local board of health might be something that you want to consider or ensure is happening. So CHACs, their real primary responsibility is to provide that advice to decision makers on implementation and making those recommendations and being advisory in nature to programs and services. So really kind of that sounding board of, this is really important. We really hope the local board considers XYZ when they're making this decision. So it really serves as that kind of advisory nature. And next slide. There are some statutory requirements as part of that local board of health expansion bill that happened in 2021. So membership criteria, there is some explicit criteria outlined in statute. So 9 to 21 community members appointed by local boards of health. Your health officer and your local board of health have ex officio positions within that. So there's a connection to your agency as well as your local board of health. And then there's members that members that would have expertise in things like healthcare, environment, social and economic, government, tribal, community-based organizations, business, and there could be other expertise and perspectives that you want to also bring into that. But there are some specific expertise that are required for that CHAC. And then in statute, responsibilities include assisting the local board of health in recruitment efforts for your LHJ leadership, using health equity as a framework for CHA CHIPS. Again, those health assessments, those health improvement processes, evaluating and providing advice on potential policies and programs. So if the health jurisdiction is thinking of starting up a new program, helping inform what that could look like, what would the impacts be, where it would be implemented, how it could be implemented, etc. It provides community forums for discussion on public health issues, helps make recommendations on things like budgets. If there's a fee discussion, it might be an opportunity to rely on business partners of like, do these fees seem reasonable? Do they make sense? Are they understood? And making other advice on other things around performance for the local health jurisdiction as well. Next slide. So a big question I think a lot of health jurisdictions have grappled with in the past and are continuing to grapple with is, do we stick with a CHAC? Do we expand the local board of health? Do we do both? So what's the best thing for our jurisdiction? And I don't have the answer. It's a home rule state. You know your communities best. You know what's best for your communities. But there's some things to consider. And this is, when I've worked with local health jurisdictions, these are often things that come up that we work through and we kind of talk about, just to kind of help them navigate, these bigger questions. So some things to consider. the size and diversity of your jurisdiction. We have some counties that are quite homogenous in terms of demographics, and we have others that are quite diverse in terms of their population. We have urban, we have rural, we have mixed counties. That might impact, are we representing community voice in a way that we feel is equitable, is community-based? Something to consider. The magnitude and complexity of health priorities that you might have. Your CHA and your CHIPs really serve as guiding documents and for your health jurisdiction and what they want to work on with their community. So, is your CHA CHIP identifying things like mental health, behavioral health, prenatal care? Are they really complex in terms of the magnitude of the issue? Does it make sense that the local health jurisdiction might expand programming and services? Is there a likelihood of additional threats and emergencies that are coming where having more community voice on the local board of health makes sense versus advisory in nature, or vice versa? There's also things to consider: pathways of additional community input and participation. Some jurisdictions have a CHAC or a CHAB. Some jurisdictions have an equity council. Some jurisdictions have regular meetings with community groups. Do you have other pathways of community engagement for your local boards of health to have that connection with your community? If you do, maybe an expanded local board of health makes sense. If you don't, and you're really leveraging something like an advisory board to be that point of contact, maybe keeping and maintaining a CHAC makes more sense. Something to think about and consider. Where is participation and input most needed? Do you want to have a space where you can have deeper conversations? You can pull in more community voice into a conversation to get really diverse membership and diverse perspectives into a conversation to help narrow down and focus recommendations so that the local board of health can focus on the decision making and the authority that they have. If that's the case, a CHAP might be best. If that doesn't necessarily make sense, maybe it's an expanded local board of health. It really, there's no right answer. It's really what feels best for your community. And then there's also things like categorization of your LHJ, county governed or special district. We have districts that are just, they've expanded their local boards of health and they have a CHAB. We have county governed LHJs that also have both. We have county governed LHJs that are just the county legislative authority because they have a CHAB. We have county governed LHJs that have expanded their local board of health because they don't have a CHAB. So that is also something to consider. Again, I don't think there's any one best path for your jurisdiction. It's really, again, leveraging your community, what your community needs. Next slide. There are benefits to having advisory boards, and I think of advisory boards as just beyond what a CHAC could be. So it could be an equity council, it could be other things. They have public input, you're getting public input and are participatory based. So you're ensuring that community voice is valued and you're really seeking a lot of diverse perspectives. And it might be more perspectives than the number of council seats that the council has. You could do an advisory board that has 21 members, you're going to have 21 different perspectives to help inform a decision. It helps prioritize services based on community need and value. It could be where, the programs and services offering need just a little tweaking to really ensure that it's meeting the community need and is of value to the community. An advisory board is going to be able to tell you, this is valuable, this isn't. We might not have known something existed, so let's market it better. you now have access to a larger group of public health messengers who can carry the voice of the local health jurisdiction, carry messages around risk communication or health education back to their communities and to the different groups that they might interact with. You can get a quicker pulse and more specific feedback from different community sectors and groups. How did this fee increase for food for restaurants go? Work with your CHAB, they will tell you how it went, right? You can get that feedback pretty immediately. Again, you're centering equity as a core value and operating principle. That might be important for your jurisdiction. And you're also assuring a very responsive and accountable local health agency. Again, it's that community connection. Next slide. There are differences between the two, and I do want to highlight those. Your local Board of Health exists in statute. You have an obligation to fulfill mandates around administration, enforcing RCWs, setting fees. So there is a statutory reason that your local Board of Health exists, and there are statutory responsibilities. So it's very governance focused. You're also setting the vision and direction of the agency. You're approving what programs and services exist, whether that's by building programs and services or approving things through a budget. You are prioritizing what you want your jurisdiction to be doing. And then you also have some community engagement responsibilities too, while it doesn't exist in statute, very important. Doing risk communications around different public health issues, for example. On the other hand, community health advisory committees, you don't have that statutory obligation around governance and administration. That obligation really exists as a recommendation and advisory position only. So the local Board of Health can say, thank you for your recommendations, thank you for your advice, thank you for your engagement. We're going to take it into account, and we might share the same view. We might not share the same view. But that Community Health Advisory Committee is really recommending things. It is a chance for further community engagement and participation. You're going deeper into the community to get that participation. Things like your CHA chip can be really well informed with your Community Health Advisory Committee. And again, you're elevating that community voice in a different way. Next slide. Both have limitations. Local Board of Health expansion is obligated to balance between elected officials and non-elected officials. That exists in statute. So your Community Health Advisory Board or committee has more flexibility for broader community membership. So for local boards of health, if you are adding a healthcare member, you're adding an elected official. If you're adding a community member, you're adding an elected official. Elected officials do mean county and city, but you're constantly balancing that perspective. CHABs allow you to have more flexibility for community membership. The CHAB model is not mandated or required. It's advisory in scope. And again, that local Board of Health holds the decision-making responsibilities. So ultimately, those decisions stay with the local Board of Health. Again, you could outline some of those responsibilities and operating principles through ordinances and resolutions local Board of Health ultimately holds decision-making power around fees, for example, but we would like the CHAB to provide recommendations on fees. So that's something where, CHAB will be tasked with discussing and making a recommendation. Ultimately, the local Board of Health is going to make the decision around it. You could outline that in a resolution, for example. And then the models have not been evaluated. They haven't been evaluated by WSALFO. They haven't been evaluated by Department of Health. They haven't been evaluated at any national level with, for example, our national affiliate NACCHO hasn't evaluated them for effectiveness or impact on health outcomes. So, the data doesn't exist to show which one is the more effective model in terms of improving community health outcomes. So I can't tell you, objectively which one is the best model. I think decentralized local governments means more local control. It gives you the flexibility to use the model which works best for your communities. Not every state has that opportunity. Other states are very more prescriptive in how local government and local boards of health operate. So we do have some flexibility in Washington state of what we want to do. And again, each county operates uniquely in Washington state of how they want to pursue this. So while there are statutory and rulemaking kind of guidelines and boxes, there is flexibility within each of those boxes where every county is going to have a slightly different process or a slightly different principle or model of practice for what they determine is best for their community. Next slide. So some things I've seen with around successful local health jurisdictions, boards, and CHABs, communication is important between all parties. So regardless of what kind of model you use, having clear communication, and especially around risk communication, there is an issue happening in your community, being consistent and having everybody receive the same message so that everybody can be good messengers is really important. Being able to promote health outcomes for your community is really, really important. Being able to promote what your LHJ does. As local boards of health, you're cheerleaders as much as you are those governing and oversights for your agency. So being able to understand and talk about the different programs is really important. Having a clear understanding of roles and responsibilities around enforcement, around budget, around policy making, all of those are really important so that local boards of health can do what they need to do to fulfill their statutory obligations. CHABs can be leveraged appropriately for that advisory and recommendations, and you're working collaboratively together versus, local boards of health didn't reach out to CHABs for this, but we had it written down. Or, CHABs thought they were making a decision on something that they actually have no authority to make a decision on. It was actually just a recommendation. So really understanding those roles and responsibilities. And that's through having consistent procedures and processes, particularly to navigate challenging or emerging issues where decisions might have to happen very quickly, or it's a very complex and hard issue where you need more community voices to think about different sides of an issue or different perspectives that might not be immediately considered because things are so fast moving. And having that cyclical engagement with government, the community, the public, the agency, really important. So you're making decisions, you're getting feedback, you're getting participation into making decisions, and it's that ongoing cyclical process. Next slide. Thank you. So that's it. Hopefully that's been helpful. I again just want to say thank you for the opportunity. These are nerdy, fun conversations to have for me. I think they're really complex conversations. And it's a good way of just talking through how do we best serve our community and ensure that communities have a chance to participate in their, in dialogue and discussions. So just want to say thank you. I know some of you are signed up to attend our local Board of Health training in a couple of weeks. So I will also see some of you there in Ellensburg to do a couple deeper dives on some of these issues as well.
Jamie, thank you so much. This is a wealth of information. I appreciate you putting this into, I think, kind of the largest context. And I want to thank you also for the WASALFO's training. I think it was the training a couple of years ago that a couple of us attended that started raising some of these questions in our minds. So stick around a little bit longer because I have a feeling there's some questions that are brewing here. So with that, I'll turn it, Councillor Little, you seem to be the first one.
Okay, thank you. Yeah, and thank you. That was very thorough. This is more of a comment, I guess. I'm really uncomfortable with the current situation where politicians are the Board of Health. this is coming from a biologist who I believe in science, and I think this is a very thoughtful council that takes expert opinion into advice. I'm thinking about future councils, future boards of health. I don't believe, I think it's kind of laughable that we think we have self-determined that we are compliant with 1152's goals of having the Board of Health have a balance between electeds and non-electeds and include experts, community members, tribal members, and lived experience. That is on our advisory group, but of course the Board of Health can completely ignore the advisory group. So I would be really interested in expanding to include those categories, so that there's not a majority. It could still have elected officials and not just county officials. But as long as it doesn't have a majority of politicians on the Board of Health, I think that would ensure the integrity of the Board of Health. So that's the direction I would be interested in going. But thank you so much for this information. Really helpful.
Thank you. Other comments? Go ahead.
Great comments. I see things similar, but a little bit differently. I think there is value for sure in having elected officials involved. For one, we are the voice of the people. I do think, however, there's also benefit in just having community members involved in the conversation. I think the experience and the wealth of knowledge that goes with the industry is absolutely pertinent to be involved in the conversation. But every once in a while, the industry can miss things that your average person can catch, important nuances and things like that. So, Jamie, thank you for coming. I think that we spent probably at least 2 hours during the WSALFO training on this particular subject. So we've kind of shrunk this down to 30 minutes. I know that Councilor Fuentes is going to be attending this year at WSALFO. I'm going to return as well. Look forward to hearing that conversation again. But I do have a couple of questions. So for me, I feel like there needs to be changes made. I do feel that the current structure is a bit off, and I've been for a long time wondering how we can change that. I don't want to completely erase the voice of the council. I think that the council is a big part of this. But I do have a question, and I was reviewing the FAC. I think the FAC is an excellent organization, and I appreciate so much all the people that are willing to dedicate the time to be on that. And I was looking through, and we have our seats maxed out at 21, which I noticed, but I found a few things in there that I feel like are really missing. One would be, we do have law enforcement, but we don't have anybody from the justice system. I think that would be important. Mental health is missing, and I think that we should get integrated into it somehow for sure. And the last thing is, I am a proponent of having every viewpoint at the table. And I think we ought to look at reserving a space for somebody that practices alternative medicine. I think that would be a beneficial addition to the group. I think anytime you bring people together that have different opinions, there's often more often than not, people come together in understanding. They begin to understand the different elements that they have not been apprised to in the past. So I think that's would be an important addition. But my question for you is, would it be possible to essentially keep the council on the Board of Health, but add people? And what I was thinking would be like individuals from the FAC actually that would do a dual role, that would participate on the FAC, but also be on the Board of Health as well. Is that even a possibility?
That is a great question, Counselor. And I would have to look at the rule again, because you have the FAC, you are exempted. But if you do choose to do the expansion, are you then obligated to fulfill the statutory requirements? That would be a question I would need to go back into the rule and kind of do a deeper dive and maybe have some conversations with State Board of Health. Certainly, you'd want to engage with your legal because you meet the exemption requirements. Do you essentially then get to do the local Board of Health the way that you want to do the local Board of Health? I don't have a good answer for you on that. But I think you raise a great point of you mentioned a lot of different healthcare expertise. With the local Board of Health expansion requirements, you'd have to go through each category first for membership. So you'd get a healthcare, a community partner, lived experience, tribal, before you get to then double dip back into healthcare. So, if you're really emphasizing we want to work very closely with our healthcare partners, we want a diverse voice of healthcare partners, working with us, that would probably be the FAC, because you would be able to, I don't want to say stack the participation and perspectives, but you would get to, you have more flexibility in who and how you would be able to create that membership than the local Board of Health. You have kind of a checklist before you get to start back over.
Okay, yeah, those are some of the things that I'm interested in looking at, and one of the reasons too is and we've consistently talked about this at the Board of Health and with the FAC and everything, is that communication is tricky. That level of communication between the FAC and the Board of Health. And I think that if you had the ability, if it's possible, to have cross members that are a member of both, right now we have just one county council that's ex facto member of the FAC. But I think more crossover would be helpful for us to better understand if we chose to continue with having 5 counselors as the Board of Health. That would help. So those are some of my initial ideas. I'm really open to anything at this point, but I do feel like that there are some changes that we could benefit from.
Thank you. Would our legal did you want to respond in some way?
Thank you, Chair. Just to state that we could always go into greater detail or discussion, or, the Board of Health could direct advice through me as your legal advisor to work on any kind of questions or things that you could have about composition and organizational structure between what the Board of Health can look like and its advisory council, or if to move more towards that idea of modeling towards an expanded Board of Health, that we can discuss that and look at those kind of modelings and see kind of the pros and cons of those and see what's best situated for Clark County and how it moves forward in the future. Because yes, as Jamie had stated, there are some pretty specific guidelines on how appointments are made within a Board of Health, but less so within an advisory council. And again, they would be advisory, so would not be able to make those decisions where the Board of Health would. So that would be part of that discussion that we could have, but something we could absolutely tee up for an agenda for the Board of Health, or if the Board of Health wanted to direct me to work on any particular work on this subject, happy to do so.
Thank you. And Councilor Young, were you suggesting that we keep a FAC and expand the Board of Health?
Yeah.
Okay.
I mean, that was my thought process. Whether we keep all 5 on the council or not is also a possibility. I'm open to either idea, but to me, the value is there in FAC. I mean, it's amazing. There's a ton of knowledge in that group, but if we can somehow better get that knowledge assimilated into the Board of Health, I think that would be a positive thing for the community.
I was also proposing to keep both.
Did you have a further comment?
Just to say that we can absolutely, again, we can go into greater detail, or we can workshop on, the requirements for the composition of a Board of Health versus an advisory committee. And we can look at those potential ideas, and we can have dialogue about that and look at potential alternatives that would be within the bounds of the law.
Yeah, I think this is going to take a few meetings to sort through and learn more. Councilor Fuentes, you have your hand up.
Thank you, Chair. And I agree. I think it's going to take some time. This is a lot of information to process. Jamie, look forward to meeting you in a couple of weeks in Ellensburg. But I share a lot of the same sentiments that the other counselors, both Counselor Young and Counselor Little, have in terms of wanting to expand the Board of Health. As Counselor Little alluded, we're not medical experts. Some of us, are believe in science and trust it. Uh, and so I think it is important to include people with that level of expertise to be able to provide feedback and guidance. So my question to you, though, Jamie, is that what is that? And I might have missed it, and I'm sorry if you did mention it, but expanding the local Board of Health from the current 5 counselors, like how far can that be expanded? How many more members can be added?
You can expand to infinity, as long as you keep equal numbers between elected officials and non-elected officials. So it's all about kind of balancing that numbers. And when I say elected officials in the statute, it also means city. So it is an opportunity to invite city council members from Vancouver, Battleground, or wherever, to also participate in the local Board of Health. So if you keep it, for example, I'll just kind of give you a scenario. If you keep it to the 5 counselors, you have the opportunity then to add 5 non-elected officials using the categorical criteria. So you'd add a healthcare, you'd add a community partner, you'd add a lived experience. If you have tribal government reservation or trust land, you'd be inviting tribal participation and tribal governments to make an appointment. And then that's 4. So then you could go back, we want another healthcare, or we want another community member, or we want somebody else with lived experience. Now, if you had, we want to do the 5-person council plus 2 city members, then it gives you a little bit more flexibility in that categorical. You still have to ensure that you have at least someone from each of those categories before you double dip into the other categories, but it can get very big very fast. And then you run into the issue of, is our board, there are best practices for board operations in terms of size too. And if you get too big as the board, then how does that impact the effectiveness of the board? And all these are questions that you all are lucky enough to get to grapple with and discuss, but things to consider as you navigate this issue.
And Jamie, just to be clear, so not all 5 counselors are required to sit on this board. So if we want to keep it at 8 or 9 counselors, right? Or excuse me, members of the local Board of Health, not all counselors have to be part of it, correct?
Correct. We have some local boards of health that have expanded so that they're like, we want 2 county elected officials. We want 2 city elected officials because we want to pull in city, but we also want to keep the size in an effective size. You could do that through your ordinance and resolutions. You have that ability to kind of navigate that a little bit more. Again, something that you all would need to discuss of, are we willing to give up that participation? Do we want to give up that participation? I don't have the answer for you. You all have
We got to figure that out.
Yep.
Yeah. And you mentioned the example really quick. You mentioned the example of 5 counselors plus 5 non-electeds. That's an even number. Would we be required to have a odd number for voting purposes?
That is where the statute is maybe not the best, in that it is even numbers, which means potential contentious votes where it's, you never want even numbers when you're in a board, right? You always want that odd number. That would be where I have seen best practices, and I would encourage in your ordinance resolution, your bylaws, your operating principles, you are clearly identifying in the event of a tie, this happens, or in the event of whatever, this happens. So that when, should it come to where, a vote is split 5-5, and I'm not, suggesting it's the elected officials on one side and the community members on the other side, but if in the event of a split vote, this would be the process. That's where those formal things can be very, very valuable.
Okay, perfect. Thank you so much. And again, see you in a couple of weeks.
Yeah, safe travels.
Counselor Belcott, did you have anything at this time?
Yes, I did. I'd like to keep both as well. Some of the other counselors mentioned that, and I really like Counselor Young's suggestion of having like a naturopathic doctor or something comparable on the board. I think that's a great idea. So thank you for mentioning that.
Okay, I have a few questions. And, you know, fundamentally, I look at this from a structural perspective, and that it would be important to have a structure that is resilient to political pressure. And so that's where, when we're all elected, you know, and we come and go, there's no guarantee we're going to be around really more than 4 years. So that, I think the council itself is a bit of a wild card. I think just that we're considering this now, it reflects an openness on the part of the council to think about these things. You mentioned that there hadn't been any evaluation of the different models in terms of which one is best. Darn. But is there anything planned to do any kind of an evaluation to have a like best practice?
Thank you, Counselor. I think NACCHO did a profile. It's outdated. A couple of the slides included their data from it. I want to say it was maybe 2015, so it's quite outdated. They're due to do something else on a national level. Now, the limitations of that is that it's national data, right? So you're getting Board of Health information from Wisconsin and California and Virginia. You know, you're getting states that are not in the same structure potentially as Washington, and you might not even be getting Washington data. I would love to do some sort of evaluation and survey. We've been very fortunate to be able to put on local Board of Health trainings through Foundational Public Health Services for our jurisdictions. With recent reductions in FPHS, that service was cut. So we're looking at how do we pivot and revamp things and work with our legislators in really emphasizing the importance of governance and that development of boards as just as important as workforce. So I'm hopeful we get to bring it back. This would be something we would be very interested in exploring in terms of, measurable, outcomes. What does that, does a structure help decision making, or does it just seem to have a level of good community engagement and satisfaction? There's a lot of ways and directions we could take an evaluation. Nothing planned at this time, unfortunately.
Great, thanks. And then, just as I've observed, I served on the FAC for a year, and then I've been on the Board of Health for coming up on 3 years. And, I think there hasn't been a lot of direct communication, although I think it's improving lately, between the FAC and the Board of Health. So I think even within the structure that we have, there's room for improvement in terms of empowering the FAC to really weigh in on decisions that the Board of Health will be making. So that's just a note to whatever structure may wind up with. The structure that we have now, we can strengthen. So there's that. And I think that, I feel like there is concern about politicizing the Board of Health. Will be, that's an issue that can come and go. So whatever resilient structure we end up with would be good. And I just want to recognize that this is a change, and we should move through our deliberations in a thoughtful way before we make a recommendation. So just some general thoughts there. Any other comments? You wanted to say something, Councilor?
Thank you. I think that's good leadership. I have a weird idea or innovative. This is probably an attorney question. What if the advisory council had a weighted vote? So say we wanted 5 electeds and 5 non-electeds. There could be 5 individuals from county, city government, and then the other 5 would be a decision made by the advisory council would be counted as 5 votes. Would that be work with the way the statute is written?
I would have to look at the statute a bit more to see how that would work, just because of the way that the statute has it compositionally, is that if you have those 5 elected officials, whether they be city or county officials, you do have to go through the process of electing 5 other, or not electing, but appointing 5 other individuals to sit on the Board of Health that would be, as stated by Jamie, somebody from the medical community, tribal, lived experience community, and that you have to have an equal number of those essentially as you cycle through. So you have to have one from each of the 4 categories before you could have a second from one of those categories again. So you have to go through this loop and process. As far as the idea of potentially having that tiebreaker be something that's put inside of the bylaws or updated via ordinance with the Board of Health, if the composition were to change, we can look into that in greater detail. It would be novel to have the idea of having the FAC or the advisory committee have essentially a tiebreaker vote in that circumstance, but it's something that we could look at and consider in what we would be considering here, which would be that expanded potentially Board of Health with also the advisory council, which would exceed what the statute says. And as most of you know here, we have code in building, but you don't have to build the code. You can build above code. That's a permissible idea too. We could build a Board of Health that is above the statute or above code in this circumstance, but that could all be, kind of discussed or weighed for options that we look at moving forward. Also too, something that the Board of Health can consider in their relationship with FAC and having it as an advisory council is, as Chair Marshall had indicated, we could leverage and utilize them more so by creating, quarterly updates or having more frequent communications or joint meetings with them to be able to have that cross-pollination, since the advisory council is an advisory council to the Board of Health. So they work under that guidance and direction from the board. So we could bridge that communication gap in other ways as well too. But again, we could
Yeah.
spend days talking about
Lots of
how we could do
options.
composition reconfiguration for the Board of Health, or how to better leverage the Board of Health that we have currently structured.
Yeah, that tiebreaker idea is interesting. I was just curious if the FAC was compliant with all those categories and we included natural path or any other ideas, if they could have that weighted vote and you wouldn't have to have redundant appointments on the Board of Health and the Advisory Council. But we'll be looking at all these in the future, it looks like. So thank you.
Sure.
Okay, I just wanted to add one note that I thought about, because ultimately, if it comes to any funding decisions, that falls back to the council. So there's no way to completely eliminate politics from ultimate decisions when it comes to funding. But go ahead, Councilor.
A little bit of expansion onto my initial thought too would be my suggestion. Again, I have no idea whether it can be done or not, but my suggestion would be, if we did have members that crossed over from FAC that were also Board of Health, that I would suggest that the body of the FAC would be the ones that would appoint those individuals. So the collective group voting on the most qualified individuals to be on the Board of Health would be an option. Something I also consider, although it seems a little bit less appealing to me at this point, would be to either keep FAC with the organizational structure that it has, or maybe shrink it just a little bit and move 2 county counselors, and that becomes the Board of Health essentially. Something similar to that. It would be redoing it complete. You would disband the FAC and recreate it, but that, gives you the concept of what I was thinking.
Okay, there's, I think, infinite possibilities here. And I think we are moving towards greater communication between the FAC and having quarterly meetings with the Board of Health. So that's all been good. And I think having a conversation with the FAC about what these options might look like and get their input would be worthwhile, and getting whatever legal parameters we'd need to operate in. And on that note, I did have a question about whether or not our chart would this how would is this represented in our charter at all, our county charter? Or if it would need any kind of revision? It is a question.
Off the top of my head, I don't have a specific answer, Chair Marshall, to that, but it's something that can definitely be looked into. Because we are a charter county, there may be something there. I just don't know directly offhand, knowing that by statute, we have to have this Board of Health for our local health jurisdiction, that has some governing precedents, but I can look into it. Absolutely.
Thank you. Go ahead.
Chair, I would also recommend, I know the last council had a briefing from our PA's office about the role of the public health officer, the doctor versus Board of Health. So I think, council has the policy oversight, but there are certain decisions that the doctor will still be making because they're the medical professional. So I think just having that clarity in your discussions as well of, what that looks like. It is a little muddy. If I remember correctly from our past discussions with the PA's office, it's a little muddy, but so like council couldn't tell Dr. Melnick how to treat a certain medical case, right? Or anything. It's really about policy. So I think, getting all the information that you want from the experts is great in setting policy, but what is that policy? What does it look like versus what does it not look like? Because that will never be influenced by an elected body.
Great. Very good point. Thank you for that. So just to try to sum up all of this, because a lot of options were tossed out, I feel like more of a brainstorming session here, but more information will be gathered. And I think we set some general direction in terms of, I feel like we flung the door open to look at options here. And then we can do that in the next several months. And I would just invite you, Dr. Melnick, I'm hoping we're not making you too nervous, if you have any thoughts that you'd like to share.
I have a lot of thoughts about this. I would recommend that you also take a look at some examples of counties that went in this direction and how it's played out. I know no formal evaluation has been done around the state, but I would encourage you to take a look at some of the other jurisdictions that have gone in this, added folks to their Board of Health and how that's played out. The other thing I'd point out is that in the FAC, I just want to point out, because I know it's been raised about healthcare folks, on our FAC right now, we have a physician, we have a nurse, we have a representative from each of the hospitals. We also have a dentist. So we have a veterinarian, because zoonotic things come up. So we have a lot of expertise on FAC. And I would just add that as well, because that's really useful. But I would encourage and take a look at how it's played out around the state over the last few years.
And just following up on that, Jamie, do you have any case studies or examples or pitfalls that you might steer us toward? Maybe not naming any names specifically.
Yes, I can connect you with some jurisdictions that I think have leaned into some of the comments that I think I'm hearing from you all around expertise, community voice, thinking about bringing perspectives onto board. So have some good examples, I think, and can connect to jurisdictions that way. I have jurisdictions that have really struggled with this, and it's been a challenge to get going. And some, the concerns are on politicization. Some examples around that as well. So I depending on who you want to talk about with what, I think I can connect you with a jurisdiction who has experienced that.
Great, thank you.
Chair.
Yes, go ahead.
If I may, we've been talking about the FAC, which is the Public Health Advisory Council, and we've been talking about seats, and I think it would be good for the public. I'm just going to go ahead and read the different seats that are assigned to FAC, if that's okay. We have somebody from the aging community, Clark County Educational Community, Clark County Federally Recognized Tribe Member, Clark County Law Enforcement Community, Clark County Youth Representative, Clark County Restaurant Association, Clark County Septic Contractors, Clark County Social and Human Services, Clark County Water Utility, Consumer of Public Health Services. There are 3 seats for that. CRESA, dentist practicing in Clark County, doctor of veterinary medicine practicing in Clark County, Legacy Salmon Creek Medical Center, medical doctor practicing in Clark County, non-elected representatives, city other than Vancouver, and non-elected representatives, city of Vancouver, nurse practicing in Clark County, Peace Health Southwest Medical Center, Clark County Health Officer ex officio, and local board of health ex officio, which for the county council, which is Councilor Fuentes at this point. And then just wanted to say thank you again to Jamie, and hopefully you'd be willing to join us for future conversations on this. It's nice to have a real kind of independent voice there when we're trying to make these decisions that impact all of us directly.
Absolutely. Thank you for the invite, and kudos to you all for having this discussion. I think it just demonstrates your commitment to public health and your support for public health and wanting to do right by your communities. So thank you for having the challenging and complex conversations. Appreciate it. And however I can support you, I'm happy to.
Great. Okay. I think with that, this work session is concluded. Thank you so much.